Systemic lupus erythematosus or SLE, or lupus, is a relatively common autoimmune systemic disorder with a prevalence of 20 to 150 cases per 100,000 population. Women in the childbearing ages are affected 9 times more commonly than men. In the United States, the African American, Hispanic, and Asian populations show higher prevalence. Along with the skin and joints, the disease involves vital organs like the brain, kidney, and blood in most patients. Because of a heterogeneous presentation and the remitting relapsing nature of the disease, diagnosis of the disorder is difficult. The kidneys are affected in many patients and are the cause of significant morbidity and mortality in this disease. The 10-year survival rate is about 70%. Like most autoimmune diseases, SLE is found in genetically predisposed patients who are influenced by epigenetic, environmental, hormonal, or other regulatory factors that trigger the appearance of the disease. Antibodies are formed to antigens in the nucleus. These antibodies form antigen-antibody complexes in the serum and are then deposited in many organs in the body, leading to the systemic expression of SLE. Formation and deposition of these bulky preformed immune complexes in and around the small blood vessels give rise to complement activation and deposition, and leads to inflammation and organ dysfunction. Immune complex deposition is a hypersensitivity type 3 reaction as defined by Gels and Coombs and is the basis for skin and kidney disease. Numerous other antibodies are formed to antigens on the red cells, causing anemia. In some patients, antibodies against phospholipids and cardiolipin give rise to the antiphospholipid syndrome, Hughes syndrome. These patients present with thrombosis or recurrent fetal loss. The antiphospholipid antibodies are also responsible for false positive rapid plasma Reagan, or RPR, a screening test for syphilis. However, the specific treponema antibody test, a confirmatory test for syphilis, is negative. In kidneys, the immune complex deposition leads to diseases ranging from minimal mesangial nephritis to diffuse proliferative glomerulonephritis leading to kidney failure. A kidney biopsy is routinely performed for diagnosis and may show increased cellularity only or thickened capillaries, wire loop lesions, in the glomerulus due to immune complex deposition in advanced disease. This can lead to necrosis and loss of glomeruli and kidney failure. Immune complex deposits can be seen on the biopsy by immunohistochemical staining or electron microscopy. The most common initial test ordered is the anti-nuclear antibody test or ANA. This is a screening test that detects all types of autoantibodies made against specific nuclear and cytoplasmic components. Many different methods can be used to detect ANA. An indirect immunofluorescent or IFA method using Hep2 cells as the substrate is commonly preferred and can detect antibodies to as many as 150 different antigens in the nucleus and the cytoplasm. Historically, rodent liver and kidney tissue was used, but was subsequently replaced by Hep2 cell substrate for ease of use and consistency of staining. The American College of Rheumatology considers ANA, IFA testing on Hep2 substrate the gold standard for ANA screening. Reporting of ANA includes a titer and pattern of staining on all positive cases. The number of specific patterns reported by a laboratory depends on the expertise in the laboratory. Other methods, such as enzyme immunoassay, or EIA, and multiplex bead assay, or MBA, are also used by laboratories to screen for ANA. The laboratory must make sure that the ANA test they use is comparable to IFA. Many EIA and MBA kits may lack some nuclear antigens and thus may not be suitable for screening purposes. ANA by its nature is a very sensitive test, but it is not very specific. A large number of normal people may have anti-nuclear antibodies without having SLE or other autoimmune diseases. Many drugs may also cause an ANA to appear. It is important that the ANA screening test is ordered in a patient that has a high likelihood of autoimmune disease so that the test is of greater value. Use of this test in random screening of patients is not useful, as up to 25% to 30% of people may be positive for ANA by IFA at a 140 titer without having any evidence of autoimmune disease. Once an ANA antibody is detected, secondary tests are ordered. Examples of these are extractable nuclear antigen, or ENA, antibodies or double-stranded DNA antibodies, which are more specific and can lead to better characterization of the disease. The dsDNA antibody may also be useful as a prognostic marker because it signifies disease activity and response to treatment status. The ENA is usually performed by EIA or MBA techniques and the dsDNA is performed by IFA, EIA, or MBA techniques. Many laboratories prefer the IFA method for dsDNA that utilizes the Crithidia luciliae organism as substrate. An ENA or dsDNA antibody test should not be ordered on an ANA-negative patient as this may waste resources and lead to false positive results. Many laboratories control the efficiency of ANA testing by proposing simple algorithms. If ANA is negative, testing stops, but if ANA is positive, the laboratory automatically initiates dsDNA and ENA antibody testing and reports results. This technique will reduce turnaround time and prevent overtesting or missing ANA-positive patients needing further follow-up of their disease. Markers of inflammation like C-reactive protein and erythrocyte sedimentation rate may be useful, but they are nonspecific, as are complement components. A low level of complement may suggest immune complex deposition and consumption of complement factors. Clinicians use the complement levels along with the dsDNA antibody to follow the patient's disease activity. Once a diagnosis is established, the patient is put on a regimen of immunosuppression with targeted therapies directed at B cells, cytokines, or all immune cells, and/or by the use of corticosteroids. Novel therapies include the use of the patient's own regulatory T cells for treatment. The disease has a remitting relapsing nature, and the management of the disease seeks to decrease the number of disease flares and to prevent end organ damage.